Hello and welcome to episode 5 from Straight from the Hip. It's Binoy from UK and Callum from Perth, Australia. Great to be back, and thank you so much for all the feedback we had for the last 2 weeks. It's really great to see that the content we are providing is useful from clinicians, and that's all is all about it, having clinical application and also making sure that it's relevant for people to apply that, because this can be a bit of a minefield. So we try to simplify things. If you do like our content, please like and subscribe and share to your colleagues. And hopefully we can get future episodes with other speakers and we can sort of deliver the content you want. How have you been, Callum? How's your week been? It's been miserable here. You must have heard on the news. It's raining non-stop and people are desperate to leave the country for the half term.
Yeah, it's all over social media. I heard it rained every day. This was up
Yes.
until a day or two ago that it rained every day in the UK for 2026 so far. So what did you guys have, like 35, 40 days worth of rain back to back?
Yeah, it's like people are saying it's like the biblical time, 40 days of rain non-stop. So is it end of the world, as they say, So it's quite wet. I think fortunately where we are, it's not much of flooding and other things. Hopefully, we got a bit of half-term break. So how's the weather up there?
Yeah, it's okay, mate. I mean, we've had one day of rain by comparison, but no, it's still summertime here in Perth. So it's at the tail end of it. We've got a few more weeks of summer, so the weather's great. Then it will go into autumn. Yeah. But I think sorry, mate. I don't miss that rain at all.
Yeah, and how about you've done some teaching for your internal people? You said you were talking about dysplasia. You're building any teaching for your team? You moved to a new team, I believe.
Yeah, so I'm in a new team now in a nice area of Perth. But yeah, I think like why you and I opened up this podcast, wasn't it? Because I think the hip and groin is such a minefield, and intra-articular hip pain like FAI. So yeah, we did a recent PD on hip dysplasia, which I think was good feedback. It's of good value. It's always making sure that, and this is where I speak to you a lot, how can we make what we're delivering valuable for clinical practice and not just giving people hot air of information, so to speak?
Yeah, and that is quite, in fact, I got really annoyed last week. I saw a patient who was like 26 who came to me. She having symptoms since the age of 21 on and off. Like the problem with dysplasia, as you know, which we'll talk in the future episode, it's so subtle, and she was more like gluteal overload and was treated as GTPS for a long time. And by the time she had X-ray, unfortunately, she had quite, significant OA. And when she was seen in UCL, unfortunately, they can't do any PA or any surgery. Now she has to wait she's on the waiting list for replacement. I mean, it's not about blaming anything. It's quite sad to see somebody very young have lost that chance for that. So I think there's still a lot more work to be done in this field. And I think you must have seen a recent post where I said the earlier you see this, they generally tend to be more aggressive and more structural than somebody who comes after 35, 40, who are more likely to, which is ironically, isn't it? You will think the younger ones will do well with conservative than somebody who is a bit more 35 will need surgery, but it's a bit different from dysplasia. So the earlier you see them, you need to have a high suspicion of early surgical referral. And that sort of comes nicely like today's topic which we have, which is on the gender difference. So what have you got for the listeners today, Callum?
Yeah, so we're still focusing on FAI a little bit more so, but as you've touched on hip dysplasia a bit there, Benoit, we will try and make some subtle links, but we will save that for a future episode. But it was just looking at what are the differences between male versus females hip and pelvises, and can that explain why one might be more subject to a CAM type deformity versus a pincer? Can they present differently clinically? Are the symptoms different? Are the rehab timeframes a bit different? So it's just hopefully increasing people's awareness of why a male and a female hip and pelvis are structurally different, and we need to just have a bit of an appreciation of that, helping people to understand that. That's what we're going into.
And I think it's, and I think that's a great point, because when we label somebody as hip impingement, it's like you have 3 patients. One could be a 24-year-old footballer with hip impingement. One could be a 36-year-old female runner with hip impingement. And in theory, they have the same diagnosis, but it's not because the presentation, the morphology. So I think a good place to start would be the morphology. So let's start with the morphology side of things. What are the key points clinicians should know from the morphology of the hip impingement, especially with regards to gender?
Yeah, a few key points that I've noted down. The first one being is that with men, and this is a very blanket statement, I'm not saying this applies to every single male in the world, But as a blanket statement, males tend to have reduced femoral anteversion and acetabular anteversion by comparison to females. So women, we know, tend to have much more anteriorly facing acetabulums and anteriorly facing femoral heads. With men, it's typically a bit more posteriorly facing. So naturally, us blokes, if you put aside the impingement, you will find that men have much more reduced passive and active hip flexion and internal range of motion compared to women, where they will have significantly more. And that's just due to the fact that there's difference in acetabular version and femoral torsion. So that'll be the first one. With males, they have generally speaking, a much thicker head-neck junction sphericity, or a much denser femoral head-neck junction in terms of circumference of their bone mass, much thicker than women. So all that means is that when a male hip goes into flexion, where we're thinking about a cam morphology, which we know we've spoken about before is more typical in males, that femoral head-neck junction abutes into the acetabulum at a much earlier range, just because they've got a thicker head-neck junction by comparison to females. Would you agree with those points?
Yeah,
with those
definitely.
2 points first off, Benoit?
Yeah. So do you think it could be because men and women have different age groups of where they have bone, consolidation, where, the bone ossification and things like that. So I think males are used to high level impact sports, especially. So one of the key questions I ask is how active you are from the age of 8 to 18. So if you've been really active, especially males, we know that from the data, they tend to have a more larger cam. So I think now we are seeing more females doing sports like football. Do you think that would change in the next 10 to 15 years? Because historically, most of the data which we've been seeing now comes from boys who've been doing football or rugby from the last 10, 15 years. So it could be also the type of sports. Do you think that could have an implication on the morphology of what they do?
Yeah. So to your first point, in terms of the ossification centers in our bone, we know that males' FAIS or ossification centers, they close quicker than females.
Yeah.
So in terms of reaching skeletal maturity, women, it tends to take a little bit longer. But you're right.
Yeah.
In terms of the prevalence data, we've got it mostly onto young lads. And that's because males have typically been much more involved in field-based cutting, high-loading type sports like soccer, rugby, hockey, basketball, things like that. So we do have majority of our data there. But now that we know that women are getting much more involved in soccer, in rugby, in those type of sports, I reckon over the next 10, 20 years, who knows? We might actually see that women are catching up in terms of developing cam morphology for similar reasons. But I do think that high intensity sport from the age of primary school, we call it in the UK, through to high school, that's definitely a big link for sure.
Yeah, definitely. And the thing is, one important point I'm sure you'll agree here is not to put in boxes. The reality is, many cases I see have a mixed picture. So they'll have a little bit of cam, bit of pincer. In fact, many studies have shown the most common type of morphology you see is a bit of mixed type. So even if the male with a large cam, they'll have a bit of pincer, and the female with standard pincer might have a little bit of cam. So it's not either or. It's generally a bit of a mixed picture, but it's knowing which is the main driver. Do you see that in your patients? A bit of a mixed type?
Yeah, 100%. But I think when we're trying to teach or deliver content, I suppose when I'm trying to teach about things to people, we sometimes have to put things into boxes to help establish a level of understanding. Yeah. So at the moment we're talking males cam, females pincer. That's a nice biomechanical, morphological way to think about it. But in the reality, you are going to get a mixed picture of things for sure. Definitely have to acknowledge that.
Yeah. Yeah, I think that moves on nicely. Is obviously this sort of things can only be picked up on imaging. So the clinicians might be more interested in the presentation of things, So how would you say, obviously there's a bit of overlap in male and female. So how would be the clinical presentation differences between a male versus female, which you see in clinic?
Yeah, and this is mostly anecdotal, so I do have to acknowledge this, and I'd be interested to hear your points, Benoit, if you would agree with this. But with males, it feels to me a little bit more clear-cut, because they'll come in and they will say that they've got anterior sort of hip flexor, groin, maybe pubic area pain. They will often describe that it can be quite a catching or a sharp pinch, blocking. Sometimes they'll even use the description of it feels like something's impinged or pinching deep,
like blocking
into my groin area. Yeah. And that's what I hear from most males. And they will typically talk about flexion, hip flexion movement patterns. So if we're talking about the gym goer, we'd be talking about any type of squatting type exercise. The lower they go into that squat movement pattern, it's increasing those symptoms. For some people, if they're doing higher load stuff, so they might be okay with a jog, but as soon as they progress that jog into a sprint, or they start doing intervals where they're running up and down hills, that can increase their symptoms. Kicking, so when we're thinking about soccer, so I'm getting used to saying soccer, Benoit, not, because if I say football in Australia, they think I'm talking AFL, Australian Football League, so I have to keep saying soccer.
Yeah.
But for our Europeans, if we're talking football and kicking, passing is generally okay.
Football.
But if they go
You're
for
still a European,
strike,
mate. You're still a European. Yeah.
Technically, I'm still European. I'm not a citizen here just
not
yet. But
any
Australians listening, I have to say soccer. But Europeans still have a British passport. That's for sure.
Yeah.
But yeah, in football, I've had lads say to me that when they shoot, when they go to strike a ball, when they go to kick a long pass, that can cause their symptoms as well. But I suppose that they're the typical things that I would see in males. With females, it feels a little bit more vague. And I think where you started off this podcast today saying that we're talking about dysplasia instability, we will talk about it in detail in a future episode. But where we know FAI and a form of hip instability very commonly coexist with females, I personally believe that's why the symptom description is much, much more vague and a bit more diffuse in their symptoms. So they could still get that anterior hip and groin pain. They might still talk about a pinching or a catching. But I also find that females will also talk about lateral hip pain. They'll talk about buttock pain. They might talk about posterior thigh pain. They'll even talk about lower back pain. And sometimes the symptoms, it doesn't take necessarily high load demanding tasks to cause their symptoms like what I would see with a male. I might get a female say to me, just standing and walking for a couple of hours going around the shops causes their pain. Sometimes just doing a linear run, not necessarily a high sprint, would cause their symptoms as well. And I get a lot more descriptions of tightness, feelings of like they've got a lack of control, like that instability, whether it's true or pseudo instability. That's where I would say anecdotally I see differences between men and women. Do you see, so is it different in your caseload?
Yeah. So I think that's a very important point here. Is one of the reasons women will get missed is because it's not straight. I totally agree. The men, I would say, a bit simpler, like presentation. They are fairly load dependent, and they clearly tell you the ags and all that. But there are 3-4 points which I think which is relevant, which I've picked up from history. Is women's symptoms are definitely more vague. It's not. It tends to move around a little bit. It can be lateral hip, buttock pain, groin, and the feeling of tightness and the feeling of trying to release it. So this is where I think a lot of women tend to spend a lot of time with the soft tissue therapists, which definitely has a place there.
Yeah.
But they tend to keep on doing it and doesn't release. But there's 2 more points which I would add here is, which is backed by the evidence, is when women tend to present with symptomatic hip impingement, like FA syndrome, they tend to be at a lower functional level than males. So, for example, I can get a male patient who's still doing the park run and still playing FAIS. But most female patients I see, they come to me at the stage where they are quite badly affected by the symptom. They've stopped their spin classes. They've modified their yoga. They feel like it's reached that level. So that's the point. And the other thing is the pain levels and the functional impairment is much higher. So although they might have subtle abnormalities on the X-ray, but clinically they present with more distress, more functional impairment, more symptoms. And obviously they're like males, they might also have the clicking, catching, symptomatic pain. So so definitely the vague element of it, the tightness, but also they tend to be a bit more affected in their symptoms and the pain levels, which is well documented, and tend to have more high levels of pain and also more functional impairment. So that's really an important point. And one reason could be is because if you look at the pincer morphology, it tends to affect the labrum first before the cartilage, whereas the cam tends to affect the cartilage more than the labrum. So we know the most painful structure is the labrum rather than the cartilage, because cartilage is avascular, neural. It doesn't feel much. So that could be one factor where women's labrum is more involved, and that's why they come with more levels of pain. So if you got somebody with an irritable hip, it's more likely not to be soft tissue, more likely to be an intra-articular, more likely to be hip impingement. So would you agree? Is something you also see? The irritability is more in women.
Yeah, I think how I would try and coin this rather to people is that with males, there tends to be more of a blockage in their movements. They can seem to tolerate a task pretty well.
Yes.
But they can feel something blocking their movements. With females, I wouldn't say they tell me something's blocking them. They've actually got very good range of movement. So whenever I'm actually teaching people to passively assess the hip with, if we just take the passive hip flexion with a male, you will probably feel that block. You'll probably feel that quite bony, hard end feel because they simply haven't got the range. That's the cam that's stopping them from getting there. When we talk about a pincer, with a female, you could probably actually get all of the range of movement that you would expect to see. You might even find excessive range of movement.
Yeah.
So it's not that they
Yeah.
can't get there. They just can't tolerate their hip being in that position.
Yes.
So a male
Yeah.
could tolerate it better. Females just can't tolerate the position. I think, as you say, it's probably to do with changes in the soft tissue structures that are primarily affected from a cam versus a pincer. So in that
Yeah.
sense, I would agree that I've seen a lady just this past week who enjoys running, but she's just stopped. That the pain's just too much. The pain's it's quite acute. It's only come on within the last month, but she's just stopped running, just given up
Yeah.
with it. Whereas I suppose with the males, they will keep running because they seem to be able to tolerate that discomfort for a longer period.
Yeah. And I think that goes nicely to the range of motion assessment and the strength and movement testings. That is, there's a misconception that people with hip impingement will always have restriction in their range of motion, especially flexion and internal rotation. But that's not the case. I see in a lot of females where they have pretty good movement and good mobility, but they feel they have to stretch it. So what do you think would be some of the key differences when we assess into the objective between male and females, between specifically looking into range of motion assessment and strength and movement strategies?
Yeah, I think this goes back to our anteversion versus retroversion analogy, difference between men and women. So with males being a bit more retroverted, if you were to passively assess a male's hip, they will have reduced hip flexion, range of movement, internal rotation. And if you were to perform these so-called special tests, like a FAIS or a Fitzgerald type test, that's probably going to provoke their symptoms quite early on. With women, as I said just a second ago, you will probably find that they have got full flexion range of movement. They've probably got a lot more internal rotation range of movement than you would expect to see as well. And I've actually had some females test negative on a Fitzgerald and a FAIS because there's no issue with their range of movement whatsoever. So I think if that does happen, that can then make you think they don't have anything wrong with their hip joint because they're clear on a FAIS or a Fitzgerald test. But that again comes back to the point of saying it's not that their hip can't get there. They have got no issue with getting there. It's just that if I was to repeatedly do a FAIS, 10 times, that might irritate their hip after 10 attempts. Whereas with a male, it will probably irritate it after just one attempt or maybe half of an attempt. We may not even get through the full test. That's probably a difference I would see in passive range of movement testing. Does that reflect your practice, or have you seen totally different in your ends, Benoit?
Yeah, definitely. Yeah, definitely. Because there could be also an element of high probability touch there, which could also make it misleading, that you might think it's more dysplastic or something like that. So the range of motion is definitely not always impaired, but they can't tolerate repeated. For example, like when they do repeated clams, which is like a sideline favor, they do like 40 or 50 clams, then they start getting really irritable. So it's more that repeated loads, and also the tolerance is poor rather than the range of motion restriction. But I think one area where I see a big difference is the strength. So do you want to tell what do you find from the strength point of view? Where is the difference?
Typically, I find that males are stronger through most of the planes of movement, but where we would find, I suppose, a deficit from the painful side to the non-painful side would be both in the frontal and in transverse planes. So if I'm getting a male or female to do anything, we'll use abduction, for example, they're weaker significantly, whether that's on a dynamometer testing, whether it's an exercise like a side plank, or whether it's a change of direction, that they don't feel as confident. They're not able to do things as powerfully or as quickly from one side to the other. But typically a male will be stronger than the female. With a male, I find that they're much stiffer, generally speaking. They don't, what's the sort of word? They've just got a much, I suppose, at the lumbar pelvic region, they're just much stiffer in their movement pattern. They're not willing to trust their entire chain. So sometimes they'll start to compensate by utilizing their lower back a little bit more, for example. So I get males saying that they've got a lot of lower back pain, just because they're much more rigid around their lumbar pelvic region. Whereas I find with women, they've got a lot more joint excursion. And maybe that is because there is a link with hypermobility, because there is a link with the hip dysplasia instability. They just have a lot more variability in their hip movements. But I would still look at a male and female and say that they are both weak in frontal and transverse planes. With a woman, I think their generic stability is poorer. They're not as rigid. That's why I say when I use the word excursion, people are not too sure what I mean by that. they've just got a lot more variability in their movement. Like if I get them to do a single leg step up, or if I do a single leg squat, or if I get them to do a hop or anything like that, there's just there's a much greater lack of control, lack of stability in the lumbar pelvic region compared to a male, where males seem to be much stiffer in their movement pattern. Yeah, I think the biggest difference between men and women is that when I'm passively assessing a male's hip, they will not have as good a flexion range of movement or internal rotation range of movement compared to women. With women, I'm actually able to probably get full, if not excessive range of movement into flexion and with internal rotation. So range of movement isn't much of an issue with women, but versus a male, there is a clear block. There is a clear lack of range of movement. If I was to do a FAIS or a Fitzgerald test on a male hip, if the symptoms are quite acute, I probably won't even be able to complete those maneuvers before a guy would say to me that's my pain, that hurts quite a lot. Whereas I've actually had cases with some women where I can do a full FAIS test or a full Fitzgerald test and they're not actually getting any symptoms. And this is where I think I've even made the mistake in the past of then thinking this lady has not got an intra-articular hip issue because it's a negative FAIS, it's a negative Fitzgerald. But that's why this podcast, I think, is so important, because to have an understanding, appreciation of the differences between a cam versus a pincer, between a male hip versus a female hip, we need to understand this, because I think I said this earlier in the podcast, range of movement isn't the problem for a female hip. They can get to those ranges. It's more that they can't tolerate those ranges of movement repeatedly. So I think, Benoit, you might have said this to me already, so I'm going to steal your quote from this, is that if you were to do a FAIS, one FAIS rep on a male hip, that would be enough. You could probably do 10 FAIS tests on a female hip, but it would take that 9th, 10th FAIS test. And then she might say to me, okay, now that's causing my hip pain. It's not, cannot get into that range. Can't tolerate repetitions of it over a period of time. Would you agree with?
Yeah, so definitely, I think that is where I think possibly one reason where it gets missed in the female population is they seem to have amazing, excellent range of motion. And then you think, oh, this can't be hip impingement, because the flexion is excellent, the internal rotation is 30 degrees. So that makes us to think that it is not present there. But again, it's the history, it's the deep achiness, the vague symptoms, the irritability, which proves that. So again, appreciating the difference between male and female is really important with range of motion. That goes nicely with the strength point of view, because this is where I think you definitely see a clear difference between the strength profile and also the movement quality, and also the lumbar pelvic dissociation. So let's analyze those areas in objective assessment with males and females, Callum.
Yeah, as a generic rule, you will find that with a male versus a female, the males will typically be stronger. So if you're using dynamometry to do your testing, you're going to find the male is going to be stronger than the female. And part of that is just physiologically, that's the normal biological difference between men and women. Where they share similarities is that the hip abductors are going to be significantly weaker from their symptomatic to their asymptomatic side. I find with males more in particular, don't know if you'd agree with this bit, Benoit, but men seem to be weaker in hip flexion. So if I test them through range in hip flexion versus a female, females actually tend to be pretty good from between the two sides. And in my theory, I've attributed that down to the fact that males do not have that hip flexion range of movement because of the cam. The cam is what's blocking that movement. So they will typically try to avoid hip flexion type tasks. Whereas with a pincer, it's not actually blocking that movement. So maybe women are not avoiding hip flexion as much as males are. And maybe that's the differences between the strength profiles. Is that what you see in your caseload?
Yeah. I think what I also see in women is there's 2-3 areas where I feel there's quite consistent differences. One is the hip abductors. Hip abductors is definitely weaker on females, and I see especially much more on the affected side. So generally, that's something. Maybe one reason is I see more of the running population, so that's something which is significant. Another big one difference is the trunk. So with men, I don't see much issues with the trunk strength. They're pretty good in the trunk strength. Whereas in women, this is really important from a rehab point of view. Pretty much most female patients, when I rehab with hip impingement, I'll definitely be including a lot of trunk work. Whereas I don't routinely do that for men. That trunk, we know that the mechanics of the trunk also affect the hips, especially when you look into like hip adduction, internal rotation. So don't forget the kinetic change. So the trunk hip abductors are definitely much more profoundly affected in women than men. Is that something you see as well?
Yeah. I mean, I see runners. I see quite a lot of male and female gym goers as well. And this is why I say with the men, they are stronger, because if you were to take a test, if you were to get them to do a single leg rise test or a single leg sit to stand,
Yes.
I see a much stiffer movement strategy in the men versus the women. So
Yes.
women, I find, have much greater movement excursion. And all we mean by that is that you could probably pick, as they're doing the movement, they might laterally shift their hips out to the sides. They might be tilting one side more than another. They might have a lot more dynamic valgus. And not that those are problems, but they are just really struggling to find ways to compensate in these movement strategies, or they're trying to utilize lots of other different muscle groups. They're trying to utilize lots of different strategies to complete a task. But with the
Yeah.
male, I don't see that. They're pretty good at it. They just can't get to that deep range of movement.
Yeah.
We'll talk about rehab in a second, but this is why I think the rehab strategy is a little bit different, where with women, you are focusing a lot more on trunk work.
Yes.
Gym goers, the guys that I see that go to the gym, they're strong. They're not
Yes.
weak.
Yes.
I don't need to worry. They're back squatting, they're deadlifting heavy stuff. Their trunk isn't
Yeah.
weak.
Yeah.
So it's just that's where the difference in rehab comes
Yeah.
into the mix as well. Yeah.
Yeah. So I think final point before we wrap up the episode, before we go to the points, is the consideration on surgical and timelines. For example, like we know that the progression is much more quicker with the cartilage damage and involvement in CAM. And also we know that surgical outcomes are slightly inferior in women with hip. So what do you think those considerations are when people are discussing about a surgical referral? And what do you think that's an important consideration when we sort of discuss into future management with both men and women?
Yeah, I think most people in their initial consultation, they're going to ask you a lot of the time, how long is this going to take to recover? How long can we
Yes.
expect the time frame before I can get back to X, Y, and Z?
Yeah.
I don't like to say that this is a sex difference, because I don't like to personally compare men and women directly to each other here to say that one is better than the other. I think this is more down to morphology. And what is the task demand that person is wanting to get back to? So if we talk about a CAM, I find that people with CAM being the biggest driver to their hip impingement, they seem to progress much quicker, and they normally get discharged from physiotherapy a lot quicker. The thing that they struggle more so is modulating their symptoms and maybe managing their loads. But they seem to get better much quicker. And I think your point earlier about the cartilage being affected first versus the labrum being affected first with women, I think is a big driver. When we're talking about surgical decisions, a CAM resection is easier. It's a simpler procedure. When we're talking about pincer morphology, and if we're starting to talk about labrums versus hip dysplasia as well, we're talking more about reconstructive, more complex procedures like a PAO. So the surgical pathways are very different, where I suppose women are going to possibly go down a much more complex surgery if that's where they're going versus a male.
Yeah.
But because, as you said, the labrum is largely affected first with a pincer versus the cartilage for a male, I think it takes a lot longer for women with a pincer morphology for their symptoms to settle down. Because there's likely elements of instability there as well, there's a lot more things that probably need to be worked on within their rehab compared to a male, and that also takes time. So as a generic time frame, I would say males with a CAM seem to do better conservatively, and they tend to do better quicker. And if they are having surgery, it's generally a simpler surgical procedure.
Probably.
With women, it seems to be on the other end.
Yeah. And I think it could all come down to one element is also their level they come to you. So I find most women, when they come to me, they are at quite more at a lower level from a function and high levels of pain. And that is always going to take time. That's true for any pathology. If somebody comes to you with less pain and they're still at a high level of playing, your rehab will be quicker than somebody who has stopped everything. They stopped running for 2 months. They're not going to the gym well. They're in a lot more pain. That is always going to take much longer than somebody who says to me, I get a bit of discomfort in the gym. I'm still doing those stuff. So in fact, that could be a key factor rather than actually gender itself is they come at different phases and different levels. So that itself is something which I'm very honest and say, like, you could have 3 patients, but they all on a different spectrum, isn't it? So we'll always have to look at the starting point. I think that comes as nicely to sort of wrap up some of the key points here. And, you can add any more points which I missed. So first thing is appreciating the gender difference, especially with the FA syndrome. The morphology is key. So CAM tends to happen generally more in more men, especially when they've done a lot of rotational sports. And we know pincer morphology, which is an acetabular coverage, which is not so much linked with the load, but it tends to be more developmental and tends to be more in women. And the main element, which there's one element of all the 5 points which have gone, is the clinical presentation. So I think the presentation here is critical, whereas with men, it's more the block, the pinching feeling, the range of motion, whereas women, it's very variable. They tend to have more that sort of the deep ache, the gluteal pain, a bit of SIJ pain, and also that irritability. And they tend to come to you with a lot more discomfort. And one of the reasons they come to you is they're not able to train at the level they want, or maybe most of them, they've stopped everything when they have trained that as well. So that's something which gone through. And the range of motion is really important, where we look into where women tend to don't have that sort of block where they go, they tend to have good range, and that could mislead you that they may not have impingement, but it's that repetitive overload and not able to tolerate it. So it's more a tolerance rather than not having it. And the strength,
Mhm.
that's another key difference. One is looking at the weakness, especially the abductors in the trunk, seems to be much more profound in women than in men, whereas men tend to be a bit more stronger. And it's more, they can't really get back to that level and repeated high impact loads where they can pretty much do most of the tasks in the gym. They're still lifting, they're still going heavy on that. And that goes finally point is being educating on the timeline. So whether it's rehab or surgery, we find from experience that the camp tends to bit more quicker, but they might struggle with the overall load. Whereas women, their baseline, because they come to us at a low baseline, it's going to be much longer. And if you look at the data for surgical options, they are also much more slower in women than in men. So it's being honest about the expectation. So this is, I think that's why we love the hips, is we see such differences in gender in no other parts of the body. For example, somebody comes with a knee OA or a shoulder pain or anything, we don't see such big difference in gender. Whereas one area of the body where we see such huge variation is hip and groin. So the gender definitely has something which we need to be mindful of. So I think that's sort of key point. Any closing message, Callum, before we wrap up this episode?
The only thing that I'm going to reiterate that you just said, and to hopefully help people avoid the mistake I made earlier in my career, just because a woman with hip pain tests negative on a FADIR Scour Fitzgerald test, please do not assume that they do not have an intra-articular pathology. And that's why
Yes.
we've done this podcast today. There could still be something going on. So
Yeah.
lean on your subjective, revisit this podcast, make sure you understand the differences between men and women so you don't make that
Yeah.
assumption.
Yeah. So same diagnosis doesn't mean same patient. It's understanding how sex and morphology shape presentation, assessment findings, and rehab priorities. So that's the key difference between both male and female presentation of hip impingement syndrome. Hope that was useful. Please like and subscribe and share this to interested colleagues. And we hope to see you on the next episode where we'll be looking into the rehab side, especially the most important one, which is the load management.
Mm-hmm.
See you soon, guys.
Take care.
Thanks.